The Knowledgeable Provider podcast is intended primarily to entertain, also to inform, but it is not a substitute for actual medical training and should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, please make an appointment to see your own knowledgeable medical provider. The opinions expressed by me and anyone else who happens to appear on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than the lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. Look, this is all for fun, okay? Don't sue me. All right, on with the show. I want to talk about screening and vaccine recommendations today. I'll talk a little bit about kids, but I don't see kids typically, so I'm not going to focus as much on the childhood vaccines, but I will try to mention those where they're pertinent. Obviously, disease prevention is one of the most important aspects of primary care. You know, we are not really saving lives in the moment most of the time, right? We're not doing surgery to directly fix someone's issue. We're not doing acute life-saving things, any kind of invasive procedures, really, most of the time. We're more playing a long game in primary care. We want people to maximize their quality of life, their lifespan, and so we want to do things now that are going to help people 20, 30, 40 years down the road. And to me, the screening especially is one of the most important things that we can go through with our patients and make sure that they are up to date on what they're supposed to have, or at least know about what they're supposed to have and what's available. Unfortunately, the guidelines are a little cumbersome to remember. They don't exactly mesh together in your head or roll off the tongue. It's just a bunch of sort of random things and numbers that you have to remember. Of course, they change over time, and sometimes there's a little bit of difference in the recommendation from each organization that puts out guidelines, right, which is super frustrating. Actually, just a few days ago, this is recorded on May 14th, 23. Just a few days ago, the USPSTF changed their recommendation for breast cancer screening. They dropped the age for mammography to 40. So that kind of stuff happens from time to time. Keeping a cheat sheet for all this can be real helpful. I used to have one on the computers in my clinic that I would just click on and pull up if I needed to refresh myself on what the recommendations were. If you can get it in your EMR as a template, that's even more helpful. Our EMR is super basic and straightforward. Everything's kind of text-based, so we don't have a lot of click boxes to deal with, but I can make my own templates for things, so I sort of just integrate the template for the screening recommendations into my template for the general physical exam, and that helps me remember what I'm supposed to be asking about and going over. Of course, all of these things have to be individualized based on a person's individual risk. So it's true with all these things. If somebody is at higher risk versus very, very low risk for something, that changes the recommendation that you might make for that individual person for that specific thing. This is not really meant to be a comprehensive review of every little detail of every guideline. I just want to give you kind of a quick and dirty overview like I would go through pretty much with a patient when I'm talking to them at their annual visit. You need to look up the individual guidelines, read the details, because it's a lot. It really is a lot. But here's a quick checklist that might be helpful for you. Just a quick note here, I always want to be as inclusive as possible and use the appropriate terminology when I'm referring to gender identity, sexual orientation, that sort of thing. So when I'm speaking about men or women, when it comes to these screening recommendations and vaccine recommendations, what I mean is people who have penises and people who have vaginas, as it applies only to their appropriate cancer screening. We'll start with screening guidelines. We already mentioned breast cancer. I think everyone's pretty much on the same page with this now, or is about to be. Mammograms start at 40, repeated every year or two. The recommendation for when to stop doing mammograms is a little bit squishy. Everything says around 75 is probably a good time to stop. We tend to just leave this up to the individual patients. If someone wants to keep doing it every year until they're 80, until they die, we're fine with that. If somebody wants to stop earlier, again, that's a thing that has to be individualized. ACOG also recommends clinical breast exams be offered every 1 to 3 years for women aged 29 to 39 and annually for women 40 or older, even after they start their mammograms. We like our patients to see a gynecologist, so we tend to leave the breast exams to them. And generally, they will also order mammograms for the patients they follow. But if you have a patient, and we do have these that don't want to go to a gynecologist or want the whole one-stop shop deal, we will certainly do clinical breast exams if they're indicated. Colon cancer screening, we start at age 45 and go usually until the mid-70s or so. The actual recommendation, again, is age 75, but generally the gastroenterologist, if they have a colonoscopy, the gastroenterologist will make recommendations about how often are they supposed to have these, how long do we want to keep doing them, etc. Usually if the colonoscopy is completely clean, they'll get a 10-year pass. If they find anything, then they'll recommend that the interval drop to 5 years or 3 years or 1 year. It's just based on each individual patient. Colonoscopy is the best thing to send people for. If they're willing to do that, that's always what we recommend. The other option we give people is the Cologuard screening. If you want to order that, it's every 3 years that you would reorder it. There are some other things out there. There's flexible sigmoidoscopy, which is not the whole colonoscopy. There's CT colonography. You can look up those different things. We don't tend to go there with our patients. We pretty much just do either colonoscopy or Cologuard test. We do have the Hemocult test, little Hemocult cards that we'll use for some patients just as a matter of their routine screening. Those are not great in my experience. Pretty much everyone I have seen that's come back positive has been a false positive so far. So those are fine, I guess, but pretty much it comes down to colonoscopy or Cologuard. Lung cancer screening. Low-dose chest CT scan is recommended every year for patients age 50 to 80 who have at least a 20-pack year smoking history, and you want to keep doing that until they turn 80 or until they have stopped smoking for 15 years. So this is a long screening recommendation. Almost as soon as I started recommending these, I caught a lung cancer in somebody who it would not have popped up in. So I'm a big proponent of this one. This is a good one. If you're going to push one of these, this is a good one to push. Aortic aneurysm screening. It's recommended that men age 65 to 75 who have ever smoked get a one-time ultrasound of the aorta to screen for aneurysms. The recommendation is not the same for women. They don't recommend doing that for women, which sounds awfully shady to me. I hope that's something that will change. A lot of people will go on their own and do these lifeline screenings where they pay, $60, $70 or something, and they do all the different vascular ultrasounds and everything. And I think that's pretty cool. As long as it's not something that costs a ton of money, to me, it's always good to have that data. So I'm a pretty big fan of those things. Cervical cancer, we encourage our patients who have cervixes to be established with a gynecologist. The recommendation currently is Pap smear for everyone age 21 to 29. That's every 3 years. For 30 to 65, it's Pap smear every 3 years. You can do every 5 years with high-risk HPV testing alone, or you can do every 5 years with the high-risk HPV testing and the Pap smear. Typically what we do is Pap every 3 years and leave it at that. After 65, we stop doing Paps. We stop doing screening unless there is some reason to continue, unless they've had an abnormal one. And obviously, if they've had a hysterectomy, you don't have to do the cervical cancer screening anymore, assuming that it was not a supracervical hysterectomy. A lot of women don't know for sure if they still have a cervix after they've had their hysterectomy. So I assume if they don't know, that means they probably don't have one, but that's one thing you may want to look into, because every once in a while you'll run into somebody who had a hysterectomy but actually still has their cervix. I also find that there's a bit of misconception among women about what a Pap smear actually screens for. Some people will say, oh, I need to keep having Pap smears because my grandmother had ovarian cancer. So sometimes it's good to explain that all we're looking for here is cervical cancer. HIV and hepatitis C. CDC recommends that everyone age 13 to 64 be screened for HIV at least once. USPSTF recommends that everyone age 18 to 79 be screened for hepatitis C at least once. I generally just ask about these together. I'll say, hey, is there any reason you would like to be screened for HIV or hepatitis? And leave it at that. And almost nobody ever takes me up on it, but I do try to at least offer. Remember, this is not a screening or vaccine thing, but I want you to remember that we now have PrEP for HIV, pre-exposure prophylaxis for HIV. At least around here, I think this is something that is still not widely thought about or offered as much as it should be. So I am going to go through the whole recommendation for that. PrEP This is CDC recommendation. PrEP should be considered for people who are HIV negative, who have had anal or vaginal sex in the past 6 months, and have a sexual partner with HIV, especially if that partner's viral load is unknown or is detectable. If they have not consistently used a condom, or if they've been diagnosed with a sexually transmitted infection, any sexually transmitted infection within the past 6 months. Also recommended for people who do not have HIV, who inject drugs, and who have an injection partner with HIV, or who share needles, syringes, or other equipment to inject drugs. Should also be considered for people who do not have HIV, but who have been prescribed non-occupational post-exposure prophylaxis in the past and report continuing the risky behavior, or who have used multiple courses of non-occupational post-exposure prophylaxis. So what that means is somebody who's been exposed to HIV not in the course of their work, right? So if you get stuck with a needle and have to do the prophylactic HIV treatment, that doesn't count. If you're sticking yourself with needles outside of work and you've had to do post-exposure prophylaxis, then you would qualify. Pneumococcal vaccines, oh my, there are a lot of caveats. This one gets real confusing. Here's what it boils down to for most people. Kids under 2 years of age should get a dose of PCV13 or PCV15, and those are going to be 4 doses. That happens at 2 months, 4 months, 6 months, and then again 12 through 15 months. Adults 65 and older, everybody should get a pneumococcal vaccine. If you're going to do the PCV15, you start with that one. A year later, you get the other one, the PPSV23. So Prevnar 15 first, a year later, Pneumovax 23. There's this newer one that I'm actually still seeing commercials for, so it's really new. It's PCV20, Prevnar 20. So if you just use that one, you don't have to do a second one. So that's what I'm recommending for my patients currently. Everybody over 65 needs 1 dose of PCV20 and then they're done. I actually heard an ad for PCV20 on the radio or on TV either today or yesterday, and I noticed that they said, continued approval may depend on the result of a supporting study. And I thought, what's up with that? So it turns out the vaccine was actually approved in some kind of fast track situation, and I guess they're waiting on more clinical trial data to get it fully approved. So there's that. The pneumococcal vaccine recommendations get a little sticky when you talk about people younger than 65. For adults, that would be people age 19 to 64. Pretty much anybody who has any sort of condition that affects their immune system or their lungs or their liver or their kidneys, or if they smoke or if they have a cochlear implant or if they drink alcohol. There's a whole list of very specific conditions, but in general, anybody who has anything like that also needs a pneumonia vaccine. If they've never had a pneumococcal vaccine before, it's the same strategy as the folks over 65. It's either 1 dose of PCV20 or the PCV15, followed by the PPSV23 after a year. If they've already had the PPSV23 for some reason, you can then give them either the PCV15 or the PCV20. Or if they've already had the older PCV13, you can then give them either the PCV20 or the PPSV23. The same general rule applies for kids ages 6 through 18. If they have those certain medical conditions, again, there's a whole specific list, but anything that affects the immune system, a cochlear implant, a CSF leak, then you want to consider pneumococcal vaccination for them as well. There you go. Perfectly clear. Again, there's a whole lot of caveats to that one, a whole lot of different scenarios, so make sure and check out the CDC website if you have any questions about that one. For tetanus, it's pretty easy. Adults need a tetanus shot every 10 years, so that's either the TD or the Tdap. Kids get a total of 5 doses of the DTaP between age 2 months and 6 years, and then a Tdap between 11 and 12 years old. COVID vaccines, of course, have been a big mess trying to keep up with through all this. That's been a huge source of consternation for a lot of my patients. I don't know if it's just because I'm in Alabama or if it's this way everywhere, but I feel like people are just over COVID vaccines at this point, don't even want to hear about it, which is unfortunate. I'm a big vaccine proponent. I'm all about a good vaccine. I've had all 5 of my COVID shots, and if I was over 65, I'd be getting the one they just recommended, but I still ask everybody about it. HPV. Again, we don't really see a lot of kids, so we don't do kids vaccinations, But HPV is one that I like to ask about because I think it's really important, and I think there's still a lot of misconceptions, misinformation out there about it. One of the pediatricians that I trained with, the way she would ask parents about it is she would say, do you want your kid to have the cancer vaccine? She wouldn't even talk about STIs or HPV or anything like that. So the recommendation is for kids to start the HPV series before they turn 15, and then so they get the first one before 15, and they get a second one 6 to 12 months after that. If they get the doses closer together, then they have to get a third one later. If they start them later on, after age 15, then you do 3 shots. It's first shot, then second shot after 1 to 2 months, and third shot after 6 months. The recommendation here is actually from 15 all the way up to 26 years old. So make sure that you're still asking your patients in their younger 20s about this. This is a relatively new vaccine that was first produced in 2006. So that means for patients who were born before like the early 1990s or so, it was not available when they were of age. I still occasionally will ask people about it if anybody's still having multiple sexual partners, any kind of high risk for HPV. They can still march down there and get a vaccine, even if they're out of the age range. They would probably have to pay cash for it. It wouldn't be covered by insurance. But that is an option to recommend to people if they're still at risk for HPV. Why not? Go get the vaccine. But the actual recommendation does go up to age 26. Influenza is an easy one. Everyone 6 months or older should get a flu vaccination every year. There are several different kinds available, and there's no real preference for what kind you get. After age 65, there are higher dose ones available, so older folks get higher dose vaccine, but everybody 6 months of age until they die, flu shot or flu vaccination every year. Remember the monkeypox outbreak that happened a while back? There is a vaccine against monkeypox, which is now just called Mpox. Here's the recommendation on that from the CDC. If you had known or suspected exposure to someone with Mpox, if you had a sex partner in the past 2 weeks who was diagnosed with Mpox, if you are, this is the CDC's wording, if you are a gay, bisexual, or other man who has sex with men, or a transgender, non-binary, or gender diverse person who in the past 6 months has had any of the following: a new diagnosis of really any sexually transmitted infection, and or more than one sex partner. New paragraph, if you have had any of the following in the past 6 months: sex at a commercial sex venue such as a sex club or bathhouse, sex related to a large commercial event or in a geographic area where Mpox virus transmission is occurring, sex in exchange for money or other items. New paragraph, if you have a sex partner with any of those above risks, so if you meet any of those criteria, or if you're having sex with anybody who meets those criteria, if you anticipate experiencing any of the above scenarios, if you have HIV or some kind of immunosuppressive situation where your risk of Mpox might be greater at some point, or of course if you work in a setting where you might be exposed to that. Mpox is a type of orthopox virus, which is kind of similar to smallpox. I don't know any more about that type of virus than that, but if you happen to work in a lab or if you work with those patients, then you would qualify to get a vaccine. That one is 2 shots given 4 weeks apart. Shingles vaccine recommended for everybody 50 and older. That's 2 shots, 2 to 6 months apart. Also recommended for folks 19 years of age and older who are immunocompromised. One thing I run into with that is that people remember that the old shingles vaccine was actually an attenuated live virus, whereas this new Shingrix vaccine is not. So that may be one misconception you need to clear up about that. Also, prior to this year, 2023, a lot of Medicare patients had an issue with the shingles vaccine being super expensive. Now, I believe starting this year, 2023, it's actually being covered a lot better. So if you have patients who went to get it and it was too expensive within the last few years, tell them to check on the price of that again. All right, I think that covers it. That didn't turn out to be quite as concise as I thought it would be, but hopefully that's a helpful, not super burdensome way to think about these vaccines and reference for you.